Hello, I'm Dr. David Musich. Before I start my presentation, I'd like to give you a brief summary of my background. Like most of us who are practicing orthodontists, our specialty career takes us to a few different locations before we settle down. In my case, I finished dental school in Chicago at Loyola University in 1969. Here is a great shot of downtown Chicago. From there, I spent 2 great years at the University of Nebraska with Sam Weinstein as chairman, then to the University of Pennsylvania, where I developed a love of orthodontic education and ultimately became a clinical professor of orthodontics at Penn in 1983. However, I moved back to Chicago in 1976 and began a full-time practice in Schaumburg, Illinois, and started teaching part-time at the University of Pennsylvania and more recently at the University of Illinois in Chicago. Each experience has created great learning opportunities for me. I achieved status of ABO certification in '85. In the following year, became a member of the Angle Society. Over the years, 2 wonderful honors have been given to me. In 2007, I became president of the Edward H. Angle Society of Orthodontists, and in 2009, I was honored with the Distinguished Service Award from the American Association of Orthodontists. Today, I've been asked to provide a mini presentation on a special type of fixed retention that I developed in 1998 following clinical research findings that came from a paper that was presented, and I'll document those presentations for you. This mini lecture will be presented in 2 parts. Part 1, rationale for the new fixed system of retention that is both flexible and passive, and Part 2, clinical steps to achieve the most reliable use of this system. Ortho FlexTech. So part 1 is going to be the rationale for the development of this system. As we know, stability remains one of the key goals of a successful orthodontic treatment program. However, stability in an aging biologic system is never perfect. Orthodontic research continues to seek treatment variables that are factors that increase or decrease stability. Today's presentation discusses the Ortho FlexTech retention system in 2 parts. Part 1, the rationale, and Part 2, patient application, clinical steps in the patient application. At this time, let's take a look at what precipitated the development of this new retention system. This goes back to learning some lessons from retreatment. As a research project for the Angle Society in the early 90s, I analyzed the records of 200 adults who had come to the practice seeking retreatment. On their health history, they had noted that they had had a previous orthodontic treatment experience. Most were referred from their general dentist for a variety of problems that were identified. The idea was to see if we could learn lessons from orthodontically treated patients who had enough post-treatment instability to be referred and to seek retreatment. This paper was presented with additional insights at the Angle Society in 2001, the AAO's annual session in 2007, and the Gianello Symposium 2010, and was recorded as part of AAO's webinar series in 2012. So let's take a look at key aspects of that research that led to the development of Ortho FlexTech. The most common problems that we're going to look at that came from this study, and these problems, the patients had multiple orthodontic issues when they presented. However, the study, we just looked at, for the time being, the most serious problems to prioritize those in our tabulation so that we could learn from those. The pie chart that you see summarizes these findings. The pie chart shows that the 3 main problem areas were lower incisor crowding, skeletal problems, that is anterior, posterior, transverse, and vertical problems, and then upper incisor crowding. The other category, up on the left-hand side of your screen, 11%, included periodontal issues, restorative issues, and TMJ problems. As indicated in this study, 39% of the retreatment sample had lower incisor shifting, and most of the changes were related to crowding and rotation. Even in this case, where her orthodontic treatment included 4 premolar extractions, the lower anterior teeth crowded. This is the area of the mouth that is like the biologic crumple zone, when the occlusal and incisal forces over time compress the arch and the equilibrium of the area changes and teeth move to accommodate the new forces. Similarly, in the upper incisor area, changes can occur and create undesirable shifting. So of our sample, that was 15% of the problems that we saw. Because of the irregularity in this area, people become self-conscious and they frequently seek treatment because of they don't like their smile anymore, or the way the teeth have darkened spaces between them or on sides of them as they rotate. In analyzing cases that had 54% of the retreatment issues, the following is a list of solutions to the anterior instability problem. Key orthodontic educators like Dr. Slick Van Arsdale and Dr. Bjorn Zacherson have supported the idea of long-term bonded retainers, but let's look at some of the other issues that are available for preventing instability. First would be to achieve optimal root torque. Second, we want proper root angulation, which our pre-angulated pre-torque systems help us achieve. Also, we want a proper finish with equilibration of large incisal marginal ridges, so those marginal ridges don't load the incisors and cause them to be moved and rotated. And lastly, or fourth, is the fibrotomy for rotated teeth. And lastly, long-term bonded retainers when indicated. And as I mentioned, Dr. Van Arsdale and Zacherson have been supporting this idea for over 2 decades. And it's an important concept that many of us have adopted to maintain our patients in a stable situation after treatment. However, in this study, we discovered that there can be a problem or a side effect with long-term bonded retainers. The retreatment study uncovered the secondary problem, a side effect of inadvertent activation causing arch distortion. This is one such patient from the study that shows the displacement and actually creation of a new malocclusion with a crossbite in the canine area and shifting of the left lateral incisor. Several of the retreatment patients had these fixed retainers that were activated. This patient was in retention for about 5 years and came in because she noticed that her bite was changing. This problem can become more alarming. This next case is one of the most advanced examples of an activated bonded fixed retainer, which shows how much change can be induced as a negative side effect. After seeing these changes in patients in the study, I began seeking a solution in the form of a passive fixed retention system to avoid these types of changes for patients whose original malocclusion required fixed retention. Recently, in the American Journal of Orthodontics and Dental-Facial Orthopedics, there was an excellent case report further illustrating the impact of an activated fixed retainer. This case shows in the lower left-hand corner the displacement of the right canine. In addition, in their case report, they documented the changes that they saw clinically using CBT images. It is worthwhile reading their case report, AJO September 2012. The CBT images speak for themselves and indicate that a great deal of orthodontic recovery treatment is needed for this patient. The advantage of the Ortho FlexTech retention system: first, it provides a high degree of long-term stability to the incisor area with very low failure rate. This is one of the examples of a retreatment patient who stopped wearing her removable retainer shortly after her original treatment, and illustrates 2 very important stabilizing aspects of the upper anterior segment. First, we did achieve very good lateral incisor labial root torque to position those teeth over the alveolar housing, and then we used a long-term Ortho FlexTech fixed retention system to further stabilize the anterior segment. Like most of us in clinical practice, the instructions of our department chairman from our graduate programs continue to echo in our brains as we treat our patients. In my case, the words and work of Sam Weinstein at the University of Nebraska helped me to reconsider the rigid spiral wire approach to fixed retention. In his paper, The Equilibrium Theory of Tooth Position, had several findings, and this was published in the Angle Orthodontist in 1963. And some of his findings are the basis for me developing this Ortho FlexTech system. Particularly of interest was conclusion number 3. Conclusion number 3 in this article stated that while differential forces, even when they are of small magnitude, if applied over a considerable period of time, can cause important changes in tooth position. I modified this conclusion to state and to be used in the development of Ortho FlexTech. Differential forces, even if small magnitude, could aid in the stabilization of corrected tooth positions. Therefore, a new solution to incisor retention problem was developed and designed to reduce adverse side effects of the activated lingual arches that we saw. This new system for long-term fixed retention has flex and is passive, with no potential for unanticipated occlusal generated load from hard candy, ice, etc., or other types of inadvertent activations, and cannot be bonded in the mouth in an active manner. Some of the advantages of this system, and there's several. First, it provides flexible enhancement to the patient's intrinsic component of incisor equilibrium, and it's easily integrated with periodic wear of a vacuum-formed removable retainer. Secondly, the passive system cannot be inadvertently activated and create undesirable tooth movement. Third, it's comfortable to the patient's tongue on initial placement due to its flat configuration. It lays flat really nicely up against the linguals of the incisors and accommodates the tongue very nicely without catching or getting major tongue irritation. 4, it provides tactile feedback to the patient if adhesive bond detaches, thereby allowing rapid repair and stabilization and avoiding potential for decalcification or decay development under a detached segment. I love this aspect. With the older spiral wire system, if an adhesive bond failed, it could go unnoticed for months or even years, and decay can develop beneath the wire and the loosened adhesive. So this does not allow that because the patient feels that area is loose and will call to get it repaired. Additional advantages: it's reasonable in cost. Both Ortho FlexTech Gold and stainless steel cost less than the price of one bracket and can be used to stabilize a 4 to 6 tooth anterior segment. Ease of placement: it's a direct bonded system that is predictable and can be bonded in place by trained staff. Lastly, Dr. Chair time is minimized during placement. In summary, the rationale for the development of a flexible passive lingual retention system came from analyzing records of orthodontic retreatment sample of 200 patients. The assessment confirmed that a long-term fixed retention system will help reduce relapse in about 54% of the patients who seek retreatment. This study also made us aware that there can be side effects with the long-term application of a spiral wire system that had been currently in use. The adverse side effects of an activated fixed retainer led to the development of Ortho FlexTech, a passive system that has the biological capacity to flex slightly when loaded. Now is a good time to proceed to part 2 of this presentation. So the steps in the placement of this system: first, you want to smooth any raised marginal ridges and remove any stain, tartar on the teeth. We like to use a carbide, football-shaped carbide and lightly go over the lingual surfaces of the teeth to be bonded. We usually will leave the arch wire in place. Sometimes we'll do a little minor adjustment of the arch wire if needed for a little in-out correction prior to placement of the Ortho FlexTech. The next step of the direct method is to use a bird beak to step the lingual arch so that it does lay passively. You can see in the slide below that frequently the marginal ridges of the canine teeth will require a little step so that it lays flat in that area. Step 3, of course, prophy or micro etch for added surface preparation. Rinse, then etch the teeth as you normally would, then rinse again with copious water and dry thoroughly. For optimal adhesion, we like to apply Assure Adhesive Booster from Reliance Corporation to the etched lingual surface according to instructions with the product. We mix the light cured resin with a small amount of light bond sealant and apply a small amount of this adhesive mixture on the lingual of each tooth to be retained. This is an adhesive undercoat. We place the adapted FlexTech chain in the applied adhesive paste on the lingual surface. We position for best alignment, take up any slack in the chain. It's usually placed in the middle third or upper third of the lower incisor segment. We then light cure the Ortho FlexTech for approximately 30 seconds to the undercoat paste to stabilize the chain on each tooth. Then we place an overcoat of LCR paste on top of the cured material to cover the Ortho FlexTech chain entirely. We want to be certain that the adhesive wraps around the chain completely. The undercoat and the overcoat merge, and do not allow the paste to drift interproximally and leave. We want to leave the interproximal chain uncovered for floss access. Ortho FlexTech is now available in white gold and new Ortho FlexTech stainless steel. The best uses are lower lingual 3-to-3 retainers following braces or removable aligner therapy. It can be used nicely on the upper lingual for lateral to lateral fixed retainers. It's also very helpful if you've aligned the teeth in phase 1. We use it frequently following phase 1 therapy, and this way we're able to frequently avoid having the 8, 9, 10-year-olds wearing removable retainers, and we basically stabilize with a fixed retention system, and then they can't lose the removable retainers and cause a disruption in the treatment process. If used on the upper to hold the diastema, we use frequently an 0175 twist as a little V-bend twist to hold the centrals, because the gold and even the stainless steel chain can stretch slightly, allowing space to reopen, which patients typically don't like very much. So we want to avoid this by using the Ortho FlexTech system. We want to avoid these activated bonded cable wires. This is again shown after 10 years of case completion, showing the major inadvertent activation of these areas in the patient's mouth. And these become major retreatment problems, and they also almost require a year or more of appliance therapy. I want to further show you the stainless steel linkage of Ortho FlexTech. This is developed in working with Reliance Corporation and was made available in 2012. Nice close-up view of the undercuts, which adds strength to its adhesion via the bonding adhesive, and does not require that the stainless steel be micro-etched, although sometimes even that would add a little bit more if you wanted to, a little bit more adhesion if you wanted to take that extra step in your office. I want to thank you for paying attention to our presentation on Ortho FlexTech. I've used this in my practice for the past 10 years, placed thousands of them, and find it to be a very reliable fixed retention system for long-term retention. And I hope you find it useful in your practice. Thank you.